In this explainer, we're going to cover iron deficiency, clinical presentation, investigation, and management. This is a comprehensive review, and we're going to follow the clinical logic cascade, all the way from the basic pathophysiology right through to the therapeutic algorithms. Now, iron deficiency doesn't just happen overnight. It's a progressive depletion, and this diagram shows it perfectly. It all begins with what we call latent deficiency. You can think of the body's iron stores as a big storage tank. At this stage, that tank is just starting to empty out. You'll see ferritin levels begin to fall, but, and this is crucial, the hemoglobin is still completely normal. Next, we move into developing deficiency. At this point, the storage tank is totally empty. The body starts to panic a little and sends out what you can think of as transport trucks, that's the transferrin, to find any iron it can. This causes the serum iron to drop while the body's total iron binding capacity, or TIBC, goes up. This is when red blood cell production starts to get hit. And finally, we reach established anemia. This is the stage where hemoglobin actually drops below the normal range, and the clinical signs we'll talk about start to appear. But the single most important takeaway here, highlighted right at the top, is this. The body's iron stores are completely gone before anemia ever shows up on a blood count. A patient can be profoundly iron deficient long before they're technically anemic.
You know, maintaining our iron levels is this incredibly delicate balancing act, kind of like the scale you see here. On one side of the scale, we have all the factors contributing to loss in demand. This includes the small amount of iron we lose every day through basal losses, but also the much bigger demands from things like menses, pregnancy, or the rapid growth spurts in childhood. Now, to keep that scale balanced, our dietary intake on the other side has to match those demands exactly. The box on the right really highlights why pregnancy is considered the ultimate stress test for this system. You've got this massive increase in the mother's red cell mass, plus a huge amount of iron is transferred directly to the fetus. And as the note at the bottom points out, infants face a very similar challenge because their growth is so explosive in those first few months of life.
This table really breaks down the main causes, or etiology, of iron deficiency into 4 neat groups. The absolute dominant cause, highlighted up there in the top left, is chronic blood loss. This is usually from either uterine sources, like heavy periods, or from somewhere in the gastrointestinal tract. Next up, we have malabsorption, where conditions like celiac disease physically prevent the body from absorbing the iron it gets from food. Then, on the bottom left, you see increased demands from situations we've already mentioned, like pregnancy or those big adolescent growth spurts. And finally, we have diet and other causes, which frankly is rarely the sole cause in developed nations. But the most critical point on this entire slide is that clinical rule at the bottom. In men and postmenopausal women, you must assume GI blood loss until it's proven otherwise. Why? Because it can take years for a normal adult male to become anemic from diet alone. There is almost always another cause at play. So what does the patient actually experience? Let's start with the general symptoms over on the left. Fatigue is by far the most common, and here's a key point. It can happen even with non-anemic iron depletion. That's when the stores are low, but the hemoglobin is still technically normal. Patients might also complain of breathlessness when they exert themselves. In kids, it can sometimes present as irritability or even a decline in cognitive function. So why do we see these very specific physical signs? Well, these epithelial changes are the result of a reduction of iron-containing enzymes in the body's tissues. This leads to the classic signs you see on the right. Pica, which is that strange craving for non-food items like ice or dirt, angular stomatitis, which are cracks at the corners of the mouth, a painless glossitis, where the tongue becomes really smooth and red, and finally koilonychia, which results in those characteristic spoon-shaped nails. And here is a fantastic close-up look at those signs we just talked about. In image A, you can see a perfect example of koilonychia. Notice how the nail has lost its normal convex curve and has actually become concave, just like a spoon. You could literally hold a drop of water in it. Image B shows angular cheilosis, with those painful-looking cracks and inflammation right at the corners of the lips. And image C gives us a clear view of atrophic glossitis. You can see how the tongue has lost its normal papillae, giving it that shiny, smooth, almost beefy red appearance. As the caption says, seeing these epithelial signs tells you that you're looking at established, chronic tissue iron depletion. This is what the blood actually looks like under a microscope in iron deficiency. On the left, you see a typical iron deficiency blood film. There are several key features pointed out. Hypochromia means the red blood cells look pale in the center because they're lacking hemoglobin. You can see pencil poikilocytes, which are these distinct, elongated, almost cigar-shaped red cells. And you can also spot target cells, which look just like a bullseye. Now, on the right is something called a dimorphic film. This is a mix of two different populations of red cells. You've got the small, pale ones typical of iron deficiency, right alongside larger, well-colored normal cells. You tend to see this during recovery, after a patient starts iron therapy, or maybe after a blood transfusion. And then over on the far right, the key lab values are summarized. You'll see a low MCV, or mean cell volume, a low MCH, or mean cell hemoglobin, and very often a raised platelet count, which is known as a reactive thrombocytosis.
This chart is absolutely crucial for figuring out not just if a patient is anemic, but what type of anemia they have. First, let's look at the normal profile. Serum iron, TIBC, and ferritin are all at a healthy baseline. Now, compare that to iron deficiency. You can see the serum iron is very low. But look at the TIBC, the total iron binding capacity. It's very high. This makes sense, right? The body is starved for iron, so it pumps out more transferrin to grab any available iron it can find. And, most importantly, the serum ferritin, which represents the iron stores, is profoundly low. The tank is completely empty. Finally, let's contrast this with anemia of chronic disease. Here, the serum iron is also low, but the TIBC is low or normal, not high. That's a key difference. It's because inflammation is actively trapping iron in the stores. The body isn't trying to find more. And this is reflected in the ferritin level, which is normal or even high. And that note at the bottom is so important. Ferritin is an acute phase reactant, meaning it can be falsely elevated during inflammation, which can sometimes mask an underlying iron deficiency. Now, while it's not a test we do every day, looking at the bone marrow is the absolute gold standard for assessing iron stores, and these images show you exactly why. On the left, you have a normal marrow sample that's been stained with Pearl's Prussian blue, a stain that specifically lights up iron. See all those bright blue flecks? That's stored iron. It's clearly visible and plentiful. Now look at the image on the right from a patient with iron deficiency. It's the same stain, but there is a stark, complete absence of any blue. The iron stores are totally gone. While this is the most definitive test, it's also invasive, and it's not typically required for a diagnosis when a simple low serum ferritin level tells you the exact same story. So let's put all these lab tests together to distinguish between the different conditions that cause this type of anemia. In iron deficiency, everything points to a lack of iron. You've got a reduced MCV, reduced serum iron, and reduced ferritin, but a raised TIBC because the body is actively searching for iron. Now contrast that with thalassemia trait. The MCV is also reduced, but the iron studies, serum iron, TIBC, and ferritin, are all normal or even raised. See, the body has plenty of iron, it just can't use it properly to make hemoglobin. Finally, look at anemia of chronic disease. The serum iron is low, just like in iron deficiency, but here's the key difference again. The TIBC is also reduced, not raised. And the ferritin is normal or high because inflammation is locking the iron away in storage. Spotting these distinct patterns in the lab work is exactly how you tell these conditions apart. This flowchart is the clinical logic we need to follow step by step. We start at the top with a patient with a confirmed case of iron deficiency. The first and most important split is based on their demographic. For a premenopausal female over on the left, the first thing you do is ask about menorrhagia, heavy periods, or a recent pregnancy. If there's a really convincing history, it's reasonable to proceed to treatment. But if not, or if the anemia doesn't get better with treatment, you absolutely must investigate the GI tract. Now for the path on the right, which applies to any male or any postmenopausal female. This path is direct and it is urgent. The red warning sign says it all. Failure to investigate the GI tract in this group is a critical clinical error. You have to assume there is GI blood loss and investigate accordingly, with endoscopies until you find a cause or rule it out.
So what happens when that initial search for a GI cause doesn't find the source of bleeding? Well, we have more advanced tools in our toolkit. The first line is typically an OGD, or a gastroscopy to look at the stomach, and a colonoscopy to look at the large bowel. If those are both inconclusive, a capsule endoscopy, where the patient literally swallows a tiny camera, can be used to visualize the entire small bowel, a place standard scopes can't reach. A duodenal biopsy is also vital to definitively rule out celiac disease, and in some cases, you might need a stool analysis to check for parasites or even an autoimmune screen to uncover some of the less common causes. The therapeutic strategy really follows 3 key steps. First, and this is without a doubt the most important, you must treat the cause. If you don't address the underlying issue, whether it's blood loss or malabsorption, the deficiency is just going to come right back. Second is oral iron. Now, the absolutely crucial point here, the one that is so often missed, is that you need to continue treatment for 3 months after the hemoglobin normalizes. Why? Because you have to refill the body's entire iron storage tank, not just fix the number on the blood count. The third step is parenteral iron, which is given by IV. This is reserved for patients who can't tolerate oral iron due to side effects or those who can't absorb it. We also have specific guidance for pregnancy, where we often start therapy if the hemoglobin or MCV drops below a certain threshold in the third trimester.
But what happens when you've started treatment and the patient comes back and their hemoglobin just isn't rising? This is an excellent troubleshooting checklist. First question to ask, compliance. Is the patient actually taking the tablets every day? Second, continuing hemorrhage. Is the patient's blood loss simply outpacing the amount of iron they're taking in? Third, could it be the wrong diagnosis? Is it possible this is actually thalassemia trait, which won't respond to iron? Fourth, is there a mixed deficiency? Perhaps there's a coexisting B12 or folate deficiency that's holding back recovery. Fifth, malabsorption. Could there be an undiagnosed celiac disease preventing the iron from being absorbed? And finally, formulation issues. Some of the slow-release preparations are notoriously poorly absorbed.
Okay, let's wrap all this up with these 5 essential clinical pearls. For diagnosis, serum ferritin is your most useful initial test, and a TIBC saturation of less than 20% confirms it. For etiology, remember, in developed nations, diet is rarely the sole cause. You must always suspect blood loss in men and postmenopausal women. For microscopy, the classic signs to look for on a blood film are microcytosis, hypochromia, and those telltale pencil cells. For treatment, do not stop iron therapy the moment the hemoglobin normalizes. You have to continue for 3 more months to properly refill the tissue stores. And finally, for history, menorrhagia is subjective. Don't just ask if periods are heavy. Ask about clots, flooding, and the need for double protection to get a more objective sense of the blood loss. These are the core learnings to take away with you.